Thank you. Yes. So I'm work locally, so I look after CML patients really right across a large part of the West Midlands. I'm based at Heartlands Hospital, now part of University Hospitals Birmingham. And I just need to advance my slides. There we go. So I've been asked to talk to you about really the first drug that Kate's alluded to, that key into that BCR-ABL protein to switch that off and to improve outcomes in CML. And I'm going to take you through a little bit of history, but hopefully not history as you knew it at school. So where are we now? And these are a ribbon diagram there that shows you the BCR-ABL protein in a format that shows you what the structure is. And then the blue area that's seated in the middle, or this drug here, that's a chemical compound that was developed here by a company called Novartis called Imatinib that sticks into that BCR-ABL pocket and switches that protein off. So where are we now? So a little bit of history, as I say, and it is a little bit of history. But we're going right back. So we're going back to 1845, and when Thackeray was writing Vanity Fair, if anybody's been watching that. And this is when John Hughes Bennett and also Virchow first described CML as this white blood, or in German, Weiss blood. And since that time, there were a number of things that were used to try to treat CML. So through arsenic, Fowler's compound, radiotherapy, hydroxycarbamide, interferon. So a number of things were used. And then during this time in 1960, the Philadelphia chromosome was identified. And then Janet Rowley in 1973 identified that first chromosome translocation, that 922 translocation. And that's part of the reason that we're meeting today on the 22nd of September, or 9/22, World CML Day. Then if we look in the really more recent past, so we're really looking at the last sort of 18 years, 20 years or so. So in 98, at Novartis, a very large conglomerate drug company, there was somebody called Brian Drucker who identified a compound that sat in the BCR-ABL protein and seemed to switch off cells in the lab. And Novartis almost didn't market this. They allowed him to produce a little tiny bit of this drug called Imatinib, as we now know it. And he, Nicholas Linden, Charles Sawyer in the US, and John Goldman in London in the UK, they were absolutely instrumental in taking this drug forward, taking it into clinical trials, really robust clinical trials, and showing the power of this drug. So much so that in Time magazine, it was described as the magic bullet, and it was really one of the first magic bullets. It's really paved the way for so many more magic bullets for other cancer patients. The patent was granted, and part of the reason I've been putting this slide up is to talk about the patent a little and what we're doing and how the future is looking with generic Imatinib. And so the patent expired in December 2016, and that led the way for generic Imatinib to be produced. Putting that into context, so this isn't me at the millennium, but just if you remember back to the millennium, we were worried about Y2K, the bug that was going to bring us all to an apocalypse, but the world didn't come to an end. And this was the date on which our first patient at Heartlands Hospital was on Imatinib in those very first pioneering drug trials. The iPod was developed. It looked like that at the time. You can't believe it now, can you? The little wheel that you spun round. Daniel Radcliffe, he looked like this. He was cast as Harry Potter. And the most popular mobile was the Nokia 3310. That looked like this. So it puts it into context, sort of where we've moved in that 18 years. I've got a few others here. Britney Spears was, oops, I did it again. We've got the Sydney Olympics. And this was the amazing image of J-Lo's green Versace dress. And that triggered Google Images. It was looked for so many times on the internet that they realised there was a need for images, and obviously our talks are made more exciting now by Google Images. So the mechanism of action of imatinib, and Kate's really nicely set this up so that you can see that the BCR-ABL protein, I'm just going to turn point. This is the ATP binding site in that BCR-ABL protein, and that sticking in of that molecule just drives it forward and drives it forward so that we get this proliferation of those myeloid cells. You get chronic myeloid leukemia. And so BCR-ABL, the tyrosine kinase inhibitors, sticks into that pocket and stops that process from being driven. So that's what imatinib was. And it was absolutely incredible, the power that that had in terms of turning around the fortunes of patients with CML. So this is what we call a survival curve. So, and if you look at the colours as they go up, the white line here, this is what was happening back in 1965 to 74 if you had CML. And you really had very little chance of surviving any more than 8 years. Many patients died within the first 3 years of their diagnosis. And over time, that pink line got a little bit better. The green line improved. But when imatinib came along on that yellow line at the top, you can see that dramatic difference where 95% of patients were surviving in those years with the CML. And at that time, we didn't know whether this would be sustained. We didn't know whether there was going to be a point at which patients with CML were going to do worse, whether this effect was going to be short-lived. But actually, as many of you know, we're now looking at whether we can stop imatinib on some patients. We're looking at the number of events that occur once you've done well on your first drug actually being lower over those ensuing years. So it's made a dramatic difference in CML. And this is another way of showing this. So this is the IRIS study, which was the landmark study, looking at the effect of imatinib as compared with the best alternative at the time. And you can see here that really, if you look at survival, overall survival at 8 years, 85%, but if you take just CML related deaths, then 93% at 8 years. So a hugely influential drug. But imatinib, is it still Mr. Incredible? And I think that's one of the things that we need to look at. There have been a number of newer drugs. So here we've got imatinib's sons and daughters. So we've got nilotinib, dasatinib, bosutinib, ponatinib. We've got a whole sweetie jar as consultants, as medics, in terms of what we choose for CML treatment. And so it's really sort of thinking, well, you know, what is the best treatment, and where does imatinib sit? And where does imatinib sit, particularly given that we've now got access to generic imatinib, which is considerably cheaper than the Novartis originator compound. This is an interesting statement that was made by Siddhartha Mukherjee. Wrote a fabulous book, if you've got time and energy to read, quite a tome, but about leukemia. He wrote The Emperor of All Maladies, was 2011 Pulitzer Prize winner. But he said in that book that in 10 years, each of us on average will know one person with this leukemia, related chronic myeloid leukemia, who is being kept alive by a targeted anti-cancer drug. He may not have been completely predictive of what was going on because, of course, he wasn't taking into account that some people may be able to stop that drug and not be being kept alive by the drug, but actually being kept alive by the effect of that drug over time. But this statement has come about partly because of the improvements that tyrosine kinase inhibitors such as imatinib have made, but also the increasing numbers of people who are surviving with CML. So that improved survival, this group have looked at the French population, but if you look before the 70s, as I say, 5% of patients were surviving 10 years. predicted around 2016, 84%, and by 2060, 90% overall survival of people with CML. So more and more people will have CML. And they looked at the incidence. As Kate said, the incidence has remained around about the same, certainly over the last decade or so. So we have 1 to 2 cases of CML that present to us per 100,000 patients. So we serve around 1 million population. So I'm seeing 10 to 12 patients with newly diagnosed CML every year will come to my practice. But those patients are surviving and surviving longer and surviving a close to normal lifespan. And so the prevalence or the number of patients that there are that have CML and that are needing treatment is increasing and is set to increase exponentially. Put another way, the French paper looked at this, so you can see that the blue bars are men and the red bars are women, but you can see starting at 1970 on this top curve here, that was the number of patients within the population proportionately with CML. And then you look at predicted in 2040, this is the explosion in CML patients that there'll be because people are being diagnosed, they're staying alive, and they're still there and requiring treatment. So in the UK, probably projected by 2040, around about 19,800 patients with CML. So just really increasing year on year on year. So I guess that brings me to talk about, I mean, we don't like as doctors to talk about cost, but Imatinib patent has expired, and so other generic forms of Imatinib can be made. So a generic drug is a completely same chemical structure as what we call the originator or reference drug, the innovator drug. So I've shown you the ball and socket joint of the compound, and so it's exactly the same compound. It's just wrapped up in slightly different things called the excipients, which we'll come to. So it's the same dosage, the same strength. It's given by the same route. It's the same quality and performance. And actually, in many cases, it's actually made in the same factory. So Sandoz was sort of fused with another company and became Novartis. And so Sandoz is still a company that can produce generics. And so often these drugs are made actually within the same factory as the originator compound, but they're no longer under the name Gleevec. So it can't be called Gleevec, it's called its generic drug name Imatinib. And so there can be differences in the way that the drug is made and crystallized. So some of the generics have been made of Imatinib for many, many years and used in places like India. So we do have a lot of data from places like India where the drug has been made often as an alpha stereoisomer rather than the beta stereoisomer that Gleevec is. But this has meant that many countries are actually ahead of the curve compared with us. So Canada, Poland have been using generics for a number of years now. As I say, India, Bosnia-Herzegovina, all have been using generics. And there are published data to show and demonstrate that there is no difference in terms of potency or how these generics work, how effective they are. The companies that make these do have to have what's called approved marketing authorization. There's a number of companies that have put up there, so these are a number of companies that are now producing this. So you may, if you're on Imatinib and you've switched to a generic Imatinib, you may start to see some of these names, which are the generic manufacturers of the drug. And the costs, they do vary a lot across the generics. There's a lot of debate about drug costs and drug companies. I'm not going to go into that in a political small p way at the moment, but the costs of generics come down, and the more companies that are producing the generics, the more competition there is. Potentially the cost of Imatinib may be 15 to 20% of the cost of the branded drug. NHS England has been procuring the generic Imatinib, and this ultimately, with the increasing numbers of CML patients that there are, may help to balance that ever-escalating cost of treatment. I will talk a little bit about Imatinib and its side effects, and certainly in my experience, some patients who switch to generic Imatinib do have slightly different side effect profile as compared with what they had with Gleevec. There are also issues such as the coating is probably slightly thinner than being used to. The tablets are a different colour. They may vary. You may get a batch that's slightly different depending on which manufacturer it's been developed from. The coating, I think, is thinner. People have reported different tastes, so the taste of generics may be different and potentially worse. And some of the side effects like sickness, nausea may change if you move on to a generic form of Imatinib. It may be completely the same, but part of that may be, I mean, it's exactly the same compound, so it may be that it's the what we call the excipients, or the things that are used to make the tablets. And basically this is a list of that in one of them, and you'll see it's, you know, things like, it sort of sounds a bit like a Haribo, which I suppose it is really. It's sort of making that compound into something that is a tablet, a takeable form. But that may vary, and that may be the reason why we see slightly different side effects that we need to keep a check on. The aim of treatment with generics is entirely the same, and Kate, I know, is going to sort of build on this this idea of what we're doing, what we're aiming for in CML. So it's basically melting that huge iceberg that we start with, those millions of cells that are in the body, and basically taking that down into a complete hematological response, so getting a normal blood count, moving to what's called a complete cytogenetic response, so that we can't detect those cells, just looking at sort of 1 cell in 100 sort of level, and then looking at a major molecular response and trying to get to what we call a stable response, where the risk of progression is actually minimal, or even getting to a MR4 or a very deep molecular response where we can consider stopping treatment. So those aims are entirely the same, whether you're on Imatinib or on a generic Imatinib form. And the reason that we have those targets is because once you get to major molecular remission, that you've got a very, very low chance of your disease changing or progressing, and your survival, if you get to that stage, is known to be the best that we can achieve. Imatinib isn't the only drug, and just to reassure that the advent of generic Imatinib does not mean that there's any different access to any of the other drugs, that they are all available through NICE pathways exactly as they have been, and that patients who don't get on with generic Imatinib, if the side effects are dramatically different, there is a pathway whereby we can go back to the Novartis Gleevec product for those patients specifically. So it hasn't really changed anything, but there is a feeling and a sense that you know, there's a change. It makes people slightly nervous, I think, having these changes. But many patients don't get on with Imatinib, can't take Imatinib. Here, this is the IRIS study again, but you know, 37% didn't have an acceptable outcome on it and needed to change, and patients will still be able to do that. So the key aim of treatment is to prevent progression while we ensure that side effects are minimised. Can we predict those patients that are likely to progress? And there are a number of ways that we've tried to do this. This is one key thing that we do, which is looking at the amount of disease that's left just after 3 months of initial treatment on Imatinib. And this was data that came from the Hammersmith Hospital. And we use this now in clinical practice really to try to predict those patients who, if they go on to Imatinib as their first-line option, Can you predict who would be best to switch, because there may be a chance that they won't hit those targets, major molecular emission, cytogenetic response. And so we take this 3-month time point is very critical. Side effects, again, I think there'll be more about side effects later on, but just to focus on Imatinib, there's a whole host of side effects that I've put on here. Muscle cramps are a big thing, periorbital edema or swelling around the eyes is very, very common. Some weight gain. I've put cardiac there though, so cardiac I think is something really to focus on with Imatinib, because we don't really understand why, but whilst many of the 2nd generation and 3rd generation tyrosine kinase inhibitors increase cardiovascular risk, can increase cholesterol, can increase the risk of diabetes, Imatinib seems to slightly but reduce the risk of cardiovascular events. And given the average age of patients with CML, or the fact that patients may be on drugs for a very long time for their CML, actually this part of Imatinib's profile actually makes it a very attractive drug for use over and above those 2nd generation tyrosine kinase inhibitors. So it's got a long track record. We do have to be cautious of drug interactions. Some of these drugs are used for, say, things like epilepsy, so it may be that they're not a good drug to choose for somebody with epilepsy, to be cautious with grapefruit juice, and there are a few other things. But in general, Imatinib has got very few drug interactions as compared with other medication. There's a slight difference in progression rates as compared with 2nd generation tyrosine kinase inhibitors. And theoretically, in some patients, it may be better to start with a 2nd generation, but actually there's been no study that has shown an increased survival rate when you do use other drugs. So the cost I've spoken about tangentially. This is a paper looking at the US cost of Gleevec, and that's escalating for a number of reasons, number of patients on it, but also the way that the drug companies alter drug costs over time. I've shown you this graph already, but this is becoming more prevalent. So we have to really think, how do we define best? What is your best treatment at the beginning? What is your best treatment going forward? And are we looking at best value, best as the fastest, or best as the safest? Best as what your quality of life is on that drug? Best as being the ability to stop that drug? Best, I would say, is really what is best when it's tailored to the individual patient and their disease. We do have to now keep an eye on value. So choosing first-line treatment is complex. We try to match drugs with the patient's personal situation, but with the advent of generics, it is likely Imatinib will be the favoured first-line treatment. 3-month time point monitoring is done to assess that early response, and we monitor milestones closely to make sure that those targets are met. So just to summarise, it's important to remember there's no evidence that generic Imatinib is any way worse in terms of survival. There's a pathway to receive originator Imatinib, Novartis' Gleevec, if the switch is unsuccessful. Adherence to medication, and especially in those first months, is a key factor to success. Thank you.